Hey everybody, I'm sorry I've been MIA, but I'm back at you. I've got a couple of vent talks for you, and in this one, I want to offer the tidbits, the pearls that I've garnered over the years that I think are clinically relevant that you can take directly to the bedside to affect your care of your intubated patient. Topics we're going to cover are going to be like knowing your why, when to get a gas, a little bit about respiratory acidosis, a bit about modes and alarms, and the last bit at the end is going to talk about metabolic acidosis and what that looks like clinically in a patient who's not intubated, and how you know when to intervene, bite the bullet, and intubate that patient. If we haven't met yet, my name's Bree. I'm a nurse practitioner. I make content for nurses, NPs, and students. Welcome. Okay, y'all, I know I've been MIA. I'm sorry. I have been working my tail off, and I know that you all have too. If I haven't said it before, bedside friends, I don't know how y'all are doing what you're doing with the staffing crunches you've got. The circumstances you're working under are just really rough, and I get it. I worked a couple shifts as a pandemic partner helping my bedside friends, and I found it hugely rewarding. Okay, so let's jump right into it. The first thing is, and I think everybody knows it, but it bears discussing, the ventilator won't cure anything. You need to know this going into it because you're going to need to tell your patient and your families this. The ventilator will not fix the problem. The ventilator will buy them time so that you can get to an accurate diagnosis and figure out a plan of care to treat them. It will give them some rest, but it's not going to fix the underlying problem. With a couple caveats. Now, if a patient has acute or chronic failure to ventilate, then it might. Okay, so your COPD that you can't turn around with BiPAP, all right, if you put them on the vent, then in 24, 48 hours, that's going to turn around. And if they're not at their end stage phase of the COPD, then yeah, you can ventilate that off and extubate them to BiPAP, and they'll probably be fine. So in that case, it probably will fix the problem. The other situation would be someone who's got chronic failure, that they've now progressed to a point that they cannot breathe for themselves. So your C-spine fractures, your patients with ALS, these are patients you should have a discussion before you intubate them, because these folks can often live a highly functional, good quality of life while supported by a ventilator. They just need to know going into it, this is for life. This is it. We're going to go immediately to trach. You're going to be supported by a ventilator for the rest of your life. The second thing, and maybe the most important, is that every single day that you're caring for a patient who's intubated, it is crucial that you keep in the forefront of your mind the reason why they went into respiratory failure. Why did they fail? Know your diagnosis because it drives your assessment. For example, if you have a patient with pneumonia who's on the vent, you're going to be assessing their secretions, their fever. Do we have a result back on our culture? Are the antibiotics that I have them on specific towards that bug? That's where your focus should be in order to fix the problem, in order to get them off the vent. Versus like your COPD or your drug overdose. Good example, right? Somebody that you intubated because they had a failure to vent because of a drug in their system, well, that's a person that you're probably going to be doing SBT trials much more frequently than the person with pneumonia. Pneumonia takes a while to fix. Overdose can wear off in a matter of hours. So you may be doing SBTs periodically throughout the day versus the pneumonia patient, it may be just once a day. So it's going to tailor your assessments. It's going to tailor your plan of care. So always know why you tubed. The third thing is going to be a little talk about the SAT/SBT, and they should be combined that way. Here's how I think about it. It's a neurological assessment associated with a pulmonary assessment, and the two need to be combined because you can't have one without the other if you're going to extubate. For the purposes of determining if a patient can be extubated, they have to go together. Okay, so you do your awakening trial, you turn off your drips, in an hour they wake up, you start by doing your neurological assessment. Can they follow commands? Do they understand what you're saying? Is there agitated delirium there and they're reaching for the tube but they're not following any commands? So neurologically, what do they understand? At that same time, don't do it yourself because nobody wants to get written up, but call your RT to push that CPAP button or that pressure support button to see if their lungs are ready to come off of a ventilator. They have to be coordinated. If they fail the trial, you have to know why they failed. You cannot just say the patient was agitated. It tells me nothing to know that a patient was agitated. They could be agitated because they couldn't breathe and it was a lung problem leading to their agitation. So I need you to drill down a little tighter into the rationale for why they're agitated. So reasons why people fail a trial. Number one, you had to abort the trial because they were hypertensive or hypotensive, typically hypertensive. They were tachycardic or bradycardic. They were hypoxic. So something on the monitor was wrong, and that's why you had to stop. Those are things I need to know. Then I want to know what the lungs are doing. Were they hypoxic? Were they tachypnic? Were they breathing too fast and too shallow? The two pieces of data I need to know from the ventilator when you do a trial are, number one, how much pressure support did they receive? So when you did your trial, how much pressure was applied from the ventilator when the patient triggered a breath? Because there's a big difference between a person who fails a trial, who's getting 0 pressure support or 5, and a patient who's getting 16. Big difference. If you fail and you're getting your pressure support of 16, you're nowhere near ready. The second thing from the vent that I need to know is something called the RSBI. And most ventilators will calculate it for you, but it's respiratory rate divided by tidal volume. This is important because it's easier to breathe fast than deep. Let me say that again. When you're sick or oversedated or profoundly weak and deconditioned because you've been on steroids and paralytics for a month, the respiratory muscles are weak, it's easy to breathe fast. And so you breathe fast, you breathe shallow. You can't take the slow, deep breaths that you need to adequately ventilate. So an RSBI is an objective way of determining that. I mean, you can tell by looking at them, but this is an objective number that tells me how they did. So tell me they failed on a pressure support of 5 with an RSBI of 120. There's going to be a video coming your way that goes much more in depth about when and how to determine if your patient's ready to extubate, so be on the lookout for that. Do you need a gas? In my opinion, not nearly as frequently as we get them. So let's go through some scenarios. Number one, do you need a gas to determine if the patient needs to be intubated? Not really. You learn a lot more by looking at the person and knowing what the diagnosis is than you do from a gas. It's just one piece of the puzzle. It's one piece of the puzzle, and it's a good piece of data to have. But do you have to wait for 3 different RTs to try a difficult stick on a patient to get a gas to tell you if they need to be intubated? No, you don't. If you're thinking they need to be, you probably should just go ahead and do it. Do you need a gas to wean oxygenation? No, you don't. Because of the oxyhemoglobin dissociation curve, there is a strong correlation between the PO2 and the SpO2 on the monitor. And if you recall on this curve, it also gives you the scenarios in which this is going to be shifted. Acidosis, fever, those are going to shift this. But there is a correlation. So if I've got a patient on a vent who's on 100% and I have 100% on the monitor, all I need to do is look at the monitor and wean it from there. Because a PO2 on the gas of 60 is going to strongly correlate with a SpO2 on the monitor of 90 or higher. Do you need a gas to determine if the patient is acidotic? Yes. Okay, this is the scenario in which you do need it. If you have a patient who's a COPDer and they're suddenly less conscious and you haven't given drugs, you need a gas. Because the end tidal does not correlate with a true CO2. Now, what I will say is that in the era of COVID, when everybody's intubated with hypoxemia, as compliance gets worse, acidosis becomes a bigger concern. So there are physicians that I round with who stand by the mantra of we need a daily gas in order to know what to do with the ventilator. I can see that argument, but if I'm practicing completely on my own, that I don't do it every day unless I'm worried something else is giving me an indication that compliance is becoming a problem. That's just my personal belief, and I know a lot of people are different on this, but that's my take on it. Number 5, don't use the term compliance. I'm just gonna advise you all to just avoid this word because I think that most people, when they use this, aren't saying what I think they're trying to say. What I hear people say is the patient's compliant with the vent. Okay. For people who understand pulmonary physiology, that means something very, very different. What I think you're trying to convey is that the patient's cool, calm, collected. They are interacting well with the machine. They're not bucking. They're not double triggering. The alarms aren't going off. They're just cool. That is a synchronous patient. So I'm going to encourage you to use the word synchrony. If a patient is synchronous with the ventilator, the mode is well matched, the sedation is optimal, and everything's chill. In an asynchronous patient, it's the opposite. They're bucking the vent, they're coughing, they're gagging, they're double triggering, they're breath stacking, Compliance is a term that tells me what's going on within the lung itself in relation to positive pressure ventilation. Compliant lung is a pliable lung. For example, someone with COPD, big hyper-aerated lungs that it's easy to push air into, it's easy to bag. The lung is very compliant and pliable versus an incompliant lung, which is getting sicker or there's something obstructing the airway. Those patients are hard to bag, they're stiff, they're in ARDS, they have fibrosis, they have a dense consolidation from a pneumonia, they have a pneumothorax. Something is making them sick and they are becoming incompliant with the ventilator. And it's just a mathematical calculation. It is change in volume over change in pressure. And it's an ever-evolving thing. You can have a one-time measurement, which is your static compliance, and you have an ever-evolving compliance, which is your dynamic. And it changes over the course of a patient's illness. So when you say the patient is incompliant with the vent, I think in my mind they're getting sicker and I need to do something about it. So I encourage you to use the word synchrony instead. There's a link to a video that I'm going to include in the description below from a guy that, I can't remember his name, but I think he calls himself like the ICU guru or something like that. And it's a terrible quality video. He's standing in a dark room in the hospital giving a lecture to staff at his place. He's got a vent going off the whole time, but it is one of the most concise and well-described talks about ventilators, peak and plateau pressures and what they mean, and compliance. So I listened to that lecture a lot when I was first understanding some of these concepts, and I'm going to refer you to that. Let's talk briefly about modes and alarms. And this is actually not going to be in depth. There's a video coming your way that's going to be just about modes and alarms. It's going to go into it a little bit deeper. What I really want to say here is that why I think it's important that you understand these things. Because I don't know about y'all. Tell me, leave some comments below. But in my training, both my undergraduate and my graduate, I think I had maybe 5 lectures on the vent, possibly. Everything I learned about ventilators was on the job and self-taught. We are blessed to work with our experts, our respiratory therapists, who are the keepers of the vent. They understand vents better than most people, and we defer to them. I mean, I don't know about y'all, but when I worked as a bedside nurse in the ICU, when the vent started screaming at me, I knew 2 sounds. I knew the sound of the alarm of the patient that came off the vent and how to quickly pop them back on, and then everything else. And pretty much everything else, all I did was run and look for the RT. And I really wish that I had spent more time trying to understand the ventilator, and this is why. So you have an RT per unit, okay? Well, or maybe you have 2. You have 1 and you have a backup. Your main RT is gone on a road trip. Your backup RT is in a code, and you've got alarms going off. And alarms affect your patient, and you need to know which alarms are emergent and which alarms just indicate that maybe the patient's getting a little worse, or the alarms are set too sensitive. You need to know which alarms warrant emergent and immediate attention. And unless you understand modes, you can't really understand what the alarms mean. So you have to dive a little bit into some understanding about the modes of the ventilator and the interaction between the patient and the ventilator to understand when a problem occurs. That's why I think it's super important at the bedside. As a provider, your main job in life is to get this patient out of the ICU. And ventilator days directly correlates with length of stay, morbidity, and mortality. And getting a patient off a vent sooner, liberating them from that vent sooner, has direct implications. And a huge part of this is understanding how to match mode with the neural drive of the patient, because you can reduce the amount of sedation and or paralysis you have to give the patient to get them synchronous with the ventilator. So you have to understand some basics about the vent. I think that's super, super important. The resources I'm going to refer you to are these, okay? This book is solid gold. Everybody should own this book if you work in an ICU in any capacity. It's easy to read. It's like 100 pages. This one is a how-to book. It is going to give you some basics about modes, but it's going to be a playbook for you. So you've intubated someone, now what? What mode do I put them on? What settings do I control on the vent? What's the best mode for them? It's also going to give you a daily assessment plan. So you go in and you look at your vent. What do you need to know from your ventilator in order to change your plan of care for the day? And then a little bit of troubleshooting. So this is an easy to read, kind of shallow dive into ventilators. When this book is not giving you enough, this book is a fabulous book. I think this is my friend's. Bridge, if you're watching, I'm going to give it back to you. Or maybe I'll just buy you a new one. This is a great book. It's a little bit harder to understand. It's a deeper dive. This is really going to help you go into the mechanics of the ventilator. It really helps with understanding waveforms. Y'all, waveforms on the ventilator, nobody ever looks at those, but they tell you so very much about the patient interaction with the vent and can be hugely helpful when it comes to diagnosing the cause of the asynchrony. And then the conference you need to go to is the Society of Chest Ventilator Course. I think it's just called the Ventilator Course. I can't remember. I'm going to try and find it. If they're still offering it, I'm going to link it down below. That's a course you need to go to live. It's the best course I've ever been to. It's so hugely helpful. It's didactic. You sit down for an hour and you have a discussion about some topic, and then you go with the group and you stand in front of a ventilator and you're presented a problem and you have to fix it on the vent, and the answer is never sedation. So it is a wonderful course to take. So sedation should be your last resort. When your patient is asynchronous, everybody's going to say, just give them a push of Versed. Just give them some rock and let's put them down so we can get this controlled. That should be your last resort. And I want you to have a high threshold for using that as your solution to the problem. And unless you understand alarms, unless you understand waveforms, unless you understand modes, it's going to be too easy to jump to this. So that's why I highly encourage you spend some time learning about your ventilator. Respiratory acidosis. Okay, this is important because pre-COVID, throw COVID out the window for a minute. Don't even think about COVID because they're a little bit different. Everybody else who's in ARDS, there's a strategy called low tidal volume, open lung, or high PEEP that was set forth by the only real pivotal study that we have on ARDS, which is the ARDSNet trial. And in that, the recommendations are the low tidal volume and the high PEEP. So because we're focusing on that as our target, because the main problem is oxygenation, we sacrifice ventilation. So we are willing to accept a pH down to like 7.2 and some hypercarbia, because patients generally tolerate respiratory acidosis pretty well. So we're willing to accept that in order to drive up our oxygenation. I say this because when you're given an ABG, you don't need to be chasing that acidosis quite as much as I think people want to push you to do. You are not going to have a perfect ABG, particularly in these COVID patients. COVID has like two phases. That's why you have your happy hypoxemic and then you have your decompensated. You have your L type and your H type. I don't know if you've heard that said before or not. But in our L type, the early COVID, where it's mostly just viral response, these patients tolerate hypoxemia far better. That's why you see them not intubated, sitting in there breathing 50 times a minute, and they're like, nope, I'm fine. Doing just fine with a SAT of 85, and they look good. They're not developing a lactic acidosis. They're perfusing, so you just kind of let them be. Those people, if they're intubated, they can handle higher tidal volumes, and they need it because they're air hungry. They can tolerate the higher tidal volumes. PEEP strategy, high PEEP strategy doesn't tend to work on these folks. So the early COVID is different. Late COVID acts much more like traditional ARDS, and that's when we go to the low tidal volume open lung strategy. Metabolic acidosis. Okay, this is important, y'all. I think this is important, especially for our bedside friends, because you have the power to be the hero in the story. If you have a good understanding of metabolic acidosis and what's acceptable and when it's time to say, nope, it's time to tube. Okay, a little bit about metabolic acidosis. You're going to see this in your septic patient, your DKAer. Most commonly being your septic patient, all right? So the body develops all this lactic acidosis because they're not perfusing, they're in shock generally. And so the body's innate, perfectly designed response to this is respiratory alkalosis, which looks like what? It looks like hyperventilation. Deep, so they can get big tidal volumes so they can increase their minute ventilation, and it's going to be fast. They're going to be breathing deep and fast. This is Kussmaul's breathing. And these are the patients that your nurse spidey sense is going to go, oh my God, this is bad. We have to stop this train or they're about to die because they're breathing so hard, and it's really scary to watch. But if you understand that this is a natural response, then you know that giving them sedation is going to kill them because you're going to take away all that drive they have. They're going to reduce their ventilation. They're going to become more acidotic, and acidotic patients code. If you know you have metabolic acidosis, you get a gas and it's metabolic, do not sedate it away. The problem with this is, if it's a septic patient, this is not something that's going to turn around quickly. So they can only breathe like that for so long. So you have to determine at what point they're too weak to continue on with that. And factors that I look at are number one is going to be neurological. Is the metabolic patient awake and talking to me and not confused? Is their GCS robust? Let them ride for a little bit. Then I look at how shocky are they. Are we on lot suppressors and have massive hemodynamic compromise? That's somebody I just go ahead and tube. The third thing is determining, is this breathing that they're doing enough? Are they having enough compensation from their natural response to ventilate off the extra acid? And you determine that real simply through a Winter's formula. It's so easy, y'all. This is something that every single person should have memorized, and should be able to calculate it like that real quickly. You need two things. This is a situation in which you need an ABG. You need the CO2 off of your ABG. You need a CMP, renal panel, BMP, some type of chemistry panel from that day, and you need to see what the bicarb is on that. Start with the metabolic acidosis. Take your bicarb off your CMP, not your gas. That's a calculated number. If you have, let's say, an ischemic bowel patient whose bicarb is 4 on the chemistry panel, you multiply this by 1.5, which gives you 6. You add 8, which is 14, and then you have a range, plus or minus 2. So it's going to be 12 to 16. That number is what you should see as your CO2 on your gas. If it's not, if you get a gas and their CO2 is normal, that's abnormal in this patient, because they need to be driving that CO2 down to that 12 to 16 mark. And if they're not there, they're not compensating enough, and that patient needs to be tubed. It's just that simple. So you have the power to gather all this information and go to your doctor and say, if we don't tube this person right now, they're going to code. And you just saved the day. That's all I got for you today. Those are my most important take homes that I think are clinically relevant at the bedside. And I cannot harp on modes and alarms enough. They're super duper important. So be on the lookout for the video that's coming next, where we talk about nothing but ventilator modes and what alarms to be on the lookout for.